Hello everyone, this is Dr. Karim Saleb and I'll be presenting the results of my study analyzing the comparative outcomes of ultrasound-assisted catheter-directed thrombolysis in low versus normal cardiac index submassive pulmonary embolism. As we all know, PE is one of the most common causes of hospitalization and mortality in the United States, and for the purpose of my study, I'm going to be focusing more on submassive or intermediate risk PE. Now, ultrasound-assisted catheter-directed thrombolysis has emerged as a potential therapeutic option due to its relatively low side effect or complication profile compared to systemic thrombolysis. Major randomized controlled trials such as the Ultima and Seattle 2 trials have demonstrated the efficacy and safety of catheter-directed thrombolysis in submassive PE. A recent study conducted by Edla et al. Showed that there was statistically significant improvement in pulmonary hemodynamic parameters such as the pulmonary vascular resistance, the right ventricular stroke work index, and the pulmonary artery pulsatility index with catheter-directed thrombolysis. Now, interestingly, two recent studies as well showed that a substantial proportions presenting with submassive PE had a low pre-procedural cardiac index despite presenting with a normal blood pressure. Now, this is important because these findings can suggest that our current risk stratification tools might not be enough to identify patients that are higher risk submassive PE patients, and those might potentially benefit with more aggressive therapy. Now, our question that we raise is whether patients with a low cardiac index compared to a normal cardiac index can actually benefit more with catheter-directed thrombolysis and demonstrate more improvements. So our first question here is whether catheter-directed thrombolysis has a greater impact in patients presenting with low cardiac index compared to those presenting with a normal cardiac index. Our second question is whether there is a difference in the post-procedural outcomes such as the 30-day mortality, procedure-related bleeding, or complications when comparing both groups. Our study was conducted via a retrospective chart review of patients that presented with submassive PE by definition, which is no hemodynamic compromise and presence of RV to LV ratio of greater than 0.9 on CT angiography. And those patients underwent catheter-directed thrombolysis in a 4-year period between 2015 and 2019. And those patients were subcategorized into two groups, a low cardiac index group and a normal cardiac index group for the purpose of our study. All the hemodynamic parameters were collected via right heart catheterization prior to catheter-directed thrombolysis, and cardiac index was calculated via fixed principle and was defined as a value of less than 2.5. All the other data was collected via review of the electronic health records and included the patient's hemodynamics, patient's demographic criteria, echocardiographic features, and so forth. We looked at 6 different parameters. One of them was echocardiographic, which was the RV to LV ratio, and there were 5 invasive parameters that we looked at, and they are all listed over here. Now, looking at the demographic characteristics of both groups, when you look closely, there wasn't any statistically significant difference between both groups, except for the BMI, which was notably higher in the patients with a normal cardiac index compared to those with a low cardiac index. All the other demographic and clinical characteristics were all non-statistically significant between both groups. So when we look at all 6 surrogate outcome measures in all 58 patients, there was improvement. We demonstrated statistically significant improvement with catheter-directed thrombolysis, and that's in all the surrogate outcome measures, and that's again a redemonstration of the previous investigations. Now, looking at the median change of these parameters between both groups, actually, the PVR was the only parameter to show a statistically significant improvement, and that was in the low cardiac index group when compared to the normal cardiac index group. But looking at all the other 4 or 5 parameters, there was no statistical significant improvement. Now, looking at the post-procedural outcomes, there were no deaths or severe or life-threatening bleeding in all 58 patients. There were a total of 6 patients that had moderate bleeding per the GOSTO criteria. The mean post-procedural length of stay between both groups was not statistically significant. Now, when we analyze the findings of our study, we again show that there was improvement in all 6 surrogate outcome measures after catheter-directed thrombolysis. However, when the patients were divided into a low cardiac index and a normal cardiac index group, that delta improvement was not statistically significant except in the PVR. Again, we show that a majority of patients presenting with submassive PE had a low pre-procedural cardiac index, and that's consistent with the previous observations. Another important thing to know that between both groups, there wasn't any difference in the post-procedural outcomes, 30-day mortality, or complications. With regards to limitations, this is again a single center retrospective and observational study, and it's also of note that the operators were aware of the initial invasive hemodynamic findings, and the possibility of bias during repeat measurement cannot be entirely excluded. So to conclude, catheter-directed thrombolysis does show consistent improvement in hemodynamic parameters in patients presenting with submassive PE. However, we think that pre-procedural cardiac index measurement should not influence the decision to proceed with catheter-directed thrombolysis based on our findings.